Happy Wednesday, everybody. I'm going to give you a couple minutes to jump on. Hope the weather's treating you well, and Thanksgiving was fabulous. And I've got a great presentation for you. I'm so excited today. So hang on a couple seconds here. Our numbers are ticking. All right. We've got a lot to go, so I'm going to go ahead and get started. Welcome to the 2023 Professional Webinar Series provided by Harmony Foundation. My name is Christy Weeks, and I am the Brand and Digital Media Manager. We are so happy that you are all here today. I've got to get my technology working again. Here we go. Today's presentation is a great one, Co-occurring Disorders, Why Families Are Key Members of the Collaborative Team, presented by Dr. Landau and Dr. Holcomb, and we are so excited both with the Arise Network. So we're so grateful they could be here today. We're going to go through a short intro to Harmony Foundation. For those of you who are new, we are located on 43 acres in Estes Park near the National Park. We've been in business for 54 years, and we are an abstinent-based program. We have about 70 beds for our residential program. We provide full medical detox. We do offer several sessions of a virtual IOP, family support and education programs, and a very, very robust alumni support services department. We offer individualized gender-specific treatment, evidence-based 12-step program, and we also provide a lifetime of support for alumni and family members because we believe that that is essential in maintaining sobriety. So if you would like to learn more about Harmony Foundation, you can visit our website at harmonyfoundationinc.com or call 970-586-4491. So a few things to know. This webinar is being recorded and it will be accessible on our website on Friday. Your CEU certificates will be available by the end of day Friday as well. You must be involved in the session for at least 45 minutes. We do have a program that tracks that, so please be aware of that. And we also have a survey coming your way. It is not required, but we certainly do appreciate your feedback. If you do not see it pop on at the end of the presentation, I will be sending it to you in the email. As far as questions go today, we will be answering questions at the end of the presentation. I know Dr. Holcomb and Dr. Landau have a great program ready for you. So, and discussion time will be at the end. So hang on to those questions. And I think that's all I have from my side. Here are our wonderful presenters. Dr. Landau, of course, president and founder of the Arise Network, and Dr. Holcomb, she is the director of Arise Training. Now, for those of you near Florida, on your way to Florida or want to go to Florida, they do have an Arise Training coming up with a couple of slots. So if you're interested, please, please, please reach out and they will provide you with the information you need. Thank you to them again for taking the time out of their day to provide this information to us. I've been looking forward to this since they agreed. So if you need to learn more about the Arise Network, the website is on the screen. And with all of that being said, let's turn this over to our two fabulous presenters. There we go.
Wonderful. Well, thank you so much for joining us today. We are so excited to have everybody on board today. We wanted to talk to you and share with you just some of our ideas and feelings about including families and understanding that they are key members with when working with a collaborative team with co-occurring disorders. As we go through the training today, we would like you to consider the following. And if you would like, you can go ahead and put those items in the chat. Judith, do you have access to change the slide? I don't have.
Yes, I do. Thank you.
Of course. So just a couple of foods for thought. As we're walking through this training seminar webinar, I wanted to kind of have you all kind of consider a couple of things. How does an individual's experience interacting with their community or environment impact their overall well-being? So that's just a question that we would like for you to kind of consider. What if these interactions are traumatic? How does an individual's genetic makeup directly impact their overall well-being? And how does a family impact the well-being of an individual struggling with a mental health and substance use disorder? And that is where we're going to sit today and talk with you guys about how it directly impacts, how families can directly impact co-occurring disorders and the treatment of, and why it's so important for them to be a key member of the collaborative team. So our learning objectives today are for you to be able to understand the importance of a collaborative approach to effectively managing co-occurring disorders, to explore the benefits of multidisciplinary collaboration for co-occurring disorders, and to explain how families are key members of the multidisciplinary treatment team. In addition to that, we're going to frame all that in transitional family therapy, which is a philosophy to integrate families and multidisciplinary treatment teams. So as I mentioned, the outline today is just looking at the current situation. Why do we need collaborative care when we're dealing with systemic trauma? The impact of transitions during times of change and crisis. What are co-occurring disorders? And why are they important for us to know? Why families need to be included in collaborative care. We're going to provide a clinical example for you and also go through transitional family therapy as an example of an evidence-based integrative approach.
So we face growing regional and global concerns from pandemics, anywhere from opiates and COVID to reemergence of intolerance, human trafficking, global climate change, terrorism, and random acts of violence. I think we're currently living through the Chinese curse of may you live in interesting times. And we all, individuals and families, are especially vulnerable during times of change. So any kind of transition, whether it's celebratory or catastrophic or sad or challenging. So think about all the transitions that you and your family have lived through in recent times and how those have impacted your mental and physical health. One of the things that is really important to know, particularly when we're dealing with co-occurring disorders, is that traumatic events result in an average of 30% increased rates of stress, attachment disorder, depression, suicide, and onset or relapse of substance use disorder, behavioral compulsions, mental health issues, and any of the other stress-related illnesses. So when we're living through major stresses, as we all have been over the last few years, that don't seem as they're going to be fading away, especially now that we're in the middle of another wave of COVID and climate change is affecting us at many, many levels. Remember that when we're dealing with our clients, the chances are that they're much more likely to have stress-related illnesses that aren't just the one that they're presenting with. So think about your own stress and the stress in your families. And with each transition, we can experience physical symptoms and not just emotional symptoms. And we each have our own distinctive stress response. And what's really interesting is that over 90% of visits to a primary care provider are driven by somatic stress, body stress. And I think we as professionals are a little more aware of that. Often our patients keep going back, the frequent flyers go back frequently because they are convinced that what they're experiencing has a physical, not an emotional basis. And somatic symptoms can serve adaptive functions in the family and then be maintained by family patterns. So where do you experience stress in your body? Can you pop the answer into the chat? Give you a minute to do that. Thank you. Yeah, you're covering the waterfront there. And our clients and their families very seldom recognize that direct link. So it's wonderful seeing how you all do. So let's look at Michelle's question about how an individual's healing journey is influenced by family. And I think looking at what's going on right now with current traumatic events, it's becoming a little more clear that everybody in the family is impacted, not just the individual. And then in terms of our involving families, families are a valuable resource as well as a support for the management of illness. I worry when people are just talking to an individual that there may be a whole bunch of things that family members may have observed that they're not sharing with us. And the family also can provide a much more accurate picture of the individual's symptoms, whether or not they're compliant, than the individual does alone. And particularly when we're dealing with one of the compulsive behaviors, whether it's substance use disorder or other, like gambling or gaming or hoarding or food, sex, individuals tend to minimize their symptoms. And I can say honestly, being in recovery for 60 years, that people with addictive diseases aren't necessarily honest all of the time. And when people come out of treatment, I think it's really important to have a collateral member of the family give us reports and not just the individual, because they want to please us if we've treated them. Families are also the primary source of many health-related beliefs and behaviors. And if the family is not included in the collaborative team, they can unconsciously become a liability rather than a resource. And that has what's tended to lead to the belief that families are bad for people. So let's take a look at families, genetics versus environment, the old story of nature or nurture. And I think there's plenty of research to show us that it's both and. There was a study of identical twins separated at birth who showed that the genetic effect of schizophrenia was only manifested as a psychiatric disorder in the presence of a disturbed family environment. The original study was done with schizophrenia, and kids adopted into healthy families, even though they had the genes for schizophrenia, were likely to be healthy, and those with no genetic predisposition, if they were adopted into a disturbed family, with schizophrenia, were likely to develop schizophrenia. So genetic and environmental variation, we always hear about epigenetics, but what we've learned is that with epigenetics, whether or not there is a gene, the environmental stresses are responsible for whether or not it manifests. So we're looking at a story of both and if people have both genetic and environmental stresses, their rate of presentation with whichever disease it is, physical or psychiatric or substance use disorder, is going to be higher. So in other words, if if environmental only, we can see stress-related development of any of these illnesses, and vice versa with genetics. And in the same way, coming from a family with a genetic loading doesn't mean people have to express the issue. For those of you who are interested, I did a TED Talk called Family Stories, Secrets, and Survival that deals in more detail with these issues. Michelle?
Yes. So what is a co-occurring disorder? Two or more of the following: substance use disorder, behavioral compulsion, physical illness, or mental illness. To recover fully, the person needs treatment for both problems concurrently, not consecutively. When we look at a recent study, a couple of recent studies, one with SAMHSA in particular, we're looking at 9.2 million adults in the US have a co-occurring disorder. That's a big chunk of people. In the United States, 9.2 million. 1 in 3 adults report both substance use disorder and a mental health disorder. 1 in 3. So if we wrap our mind around that in terms of what we do as, mental health providers, it can be overwhelming. We can't just look at, a particular client or a particular client family as individualized. We have to look at them through a whole different lens and know that there's more than one thing going on with a particular individual, and that sits in a family system. So of all those diagnosed as mentally ill, 29% of abuse was either with alcohol or drugs. So when we're looking at this, we understand that co-occurring disorders is really an expectation at this point. It's not really the exception like it used to seem like. So co-occurring disorders that are commonly misdiagnosed, just kind of looking at this list: learning disabilities, mild traumatic brain injuries, thyroid or endocrine diseases, hypertension, diabetes, compulsive eating, PTSD, addiction, postpartum depression, PMDD, when 2 or more physical, mental, or emotional conditions exist concurrently. So these are some of the co-occurring conditions that are often misdiagnosed or overlooked by either the physicians or the mental health providers. How many of you guys, you can do a show of hands in the chat if you'd like, but how many of you guys are now, when you go to your primary care physician, how many of you guys, if you need a heart screening or you need something in particular, you are then sent to 5 specialists in order to, kind of resolve the issue? And so what we're seeing now with medical care and mental health care in general is that specialization in the healthcare field has actually created fragmentation. I don't know about you all, but I am a therapist by trade, and it's really, really difficult sometimes to collaborate with other professionals. If I'm seeing a client, sometimes it's really, really difficult to partner with the primary care physician or partner with the psychiatrist. I'll send an ROI and I never hear back, and then I send another ROI and I never hear back. And so that is, for me as a practitioner, it's very, very frustrating. And unfortunately, the more that we've gotten into healthcare and specialization, the more it's created fragmentation. So we're focused on isolated body parts rather than the whole individual, which we see in medical care happening quite a bit because, as we know, insurance drives how we do things in the medical field. But, I think that's one of the challenges that we have as professionals. One of the things that I hear Judith talk about a lot is she's one of the last psychiatrists that actually do therapy. It seems like now there's a trend where psychiatrists only do medication, and really they don't have the time or the bandwidth to do the therapy as well. And so it's no longer a one-stop shop, even from a psychiatric providing psychiatric support, but it is fragmented as well. On that note, people are often seen as individuals in isolation rather than family members, than members as a unique social, environmental, and cultural context. And I know that this is something we often see when, as therapists, we're treating individual clients. Sometimes we don't see the bigger picture of what is happening in their social environment, what's happening with them culturally, and are we even considering the family roots or any sort of intergenerational trauma or any sort of intergenerational patterns when we're treating individual clients as a mental health provider or a health provider in general. They're really, really critical to look at it from a broader scope in order to really treat and provide long-term care to clients. Advancements in Western society have resulted in more holistic approaches to healing and wellness. So that can be the positive side of things. And moving on, go ahead.
Yeah. So one of the classic examples of fragmentation of services is treatment of obesity. And there are many examples of problems like this that result in competing and typically, the way Michelle has described, non-collaborative services. So if we look at obesity, which comes to us very often as compulsive eating disorder, with or without bulimia, and we can look at anorexia as the other side of the coin with very similar things. And if we look at how the fragmentation happens, it's a great example of the need for multidisciplinary services. Nutritionists treat dietary habits. Fitness coaches treat exercise habits. Internists treat blood pressure and cholesterol levels and monitor weight. Endocrinologists explore the underlying endocrine disorder. Addiction specialists treat overeating habits. Surgeons perform gastric bypass, gastric banding, and gastric sleeve surgeries. Cardiologists treat related heart disease. Psychiatrists or therapists treat the depression. And the internists now provide medication as well. So depending which door people enter, that can keep them in that doorway or that office for years with no attention to what's happening to the rest of that human being or their families. So if you happen to be the entry point, one of your first questions is, what do I need to be looking at before I just treat what's being presented to me? Alas, none of these specialists has the cure for obesity. A patient might find short-term weight loss success through an intensive exercise program, weight loss medication, surgery, dietary changes, but as with any complex chronic relapsing disease or addiction, rarely are these short-term successes sustained. And it's because without addressing the emotional, psychosocial triggers of any complex chronic or relapsing disease, acute flare-ups can be expected repeatedly and frequently. And conversely, without addressing the medical issues, we see the same thing. So it's, these are salutary examples of how we need to be thinking as we start doing an intake with somebody focusing only on one area that they're presenting to us. And there's a lot of talk about trauma-informed work. And I think one of the things that I feel very strongly about is that the other side of the coin of trauma is resilience. How we integrate what we've experienced to become stronger and more resilient and able to access our resources. So loss and trauma can precipitate any of these stress-related illnesses, including addiction, mental illness, physical illness, or relapse of any of them. Treating one without the other will not succeed. Addiction without dual diagnosis still requires collaborative care. Mental health challenges without dual diagnosis also requires collaborative care. So we need collaborative care for all co-occurring disorders. 60% of people receiving integrated care achieve substance abuse remission, but only 20% of those receiving separate SUD and mental health treatment acquire remission. So the importance of this is huge.
So thinking in terms of common barriers to multidisciplinary collaboration, I did mention one, stigma, geography, lack of interdisciplinary organization, poor communication, ethical differences, financial challenges, and cultural differences. So what are some barriers in treating co-occurring disorders? Patients struggle with more than one of the following: worse psychiatric symptoms, poor treatment compliance, worse prognosis, use more treatment and service resources, have a great propensity for suicidal or self-harming behaviors, and poor physical health habits. We know when we have multiple things going on at once, it is very difficult to kind of stabilize as far as mental health is concerned. And so the more we have on our plate, the more difficult it can be to be able to regulate. Have fewer social supports or financial resources with which to seek treatment other than on an outpatient basis from the public sector of community providers. So that's one of the things that we're seeing in the mental health and health treatment world, is there are barriers for people that are struggling with co-occurring disorders. The more we have on our plate, like I mentioned, the more difficult it is to manage. And when we have the fragmentation and specialization, a lot of times patients, clients, families, they don't know where to start and they don't know where to go because the system is so fragmented. Go ahead, Judith. I'm sorry.
Yeah, I think one of my worst experiences recently was having been called to work with the family of a young man who the family had decided to send to a treatment center that I had never used. And he was in for 30 days and then 30 days of sober living. And during all that time, I couldn't reach a single member of the treatment team or person even working at the treatment center to be able to collaborate and help the family know what was going on. So neither they nor I. And it was about 2 months after discharge that I called from the therapist saying that their director said they were too busy to collaborate.
Wow.
Yeah.
That's a perfect example, Judith, of what we're talking about and why it is frustrating for not only patients, but also providers to be able to provide, great support for families and individuals. It can be very frustrating for us as healthcare providers as well. And sometimes when we accept that process, then we aren't able to provide really good collaborative care. I'm very persistent in reaching out to people, but you can only do so much on your end. And then what do you do if people don't call you back or they're not willing to collaborate? You're really, really stuck as a provider. So it does create a frustration, and it does create, a longer process for the patient or client, which is pretty unfortunate.
And likely a relapse.
Absolutely. Absolutely. We put our clients in more danger in that way, in a lot of ways, mentally, physically, emotionally. So when we're looking at intergenerational history of substance abuse or mental illness, the family may have developed dysfunctional patterns, and that's a barrier as well. And so sometimes there's patterns that families have developed, whether we're working with, minors or even adults, that those patterns can get in the way of treating co-occurring disorders. That is why it's so incredibly important. If there's any take-home message today with this presentation and what Judith and I have to share with you, that It is so incredibly important to get the intergenerational history of a family and really consider the family when treating patients, clients, the people that you work with.
Mhm.
Fear of violence to self or others is another one. I think co-occurring disorders can be, you know, pretty severe or pretty serious. And so I think sometimes that can be a barrier for treatment as well. People kind of want to run away from it instead of being able to support
Mhm.
whether family members or providers.
Yeah, I was doing a presentation to, really a discussion with family members of severely mentally ill patients. And one of the mothers said something that I have never forgotten, which was, it's lonely. This is not a casserole disease. And it really struck me that, if somebody has an acute illness, a broken bone, people bring casseroles, they bring flowers, they support the family. But the social stigma of SUD, of gambling and losing everything for the family, of mental illness, particularly serious mental illness, people avoid social support. And it's a huge piece about, how does each of us work to change the social stigma? I think NAMI has done a really good job with serious mental illness, but we still have a long way to go, even with that, and particularly with any of the behavioral compulsions. It's obesity is one of the few things where people will stop someone on the street and tell them, why don't they exercise or eat less?
It's a perfect example. So how do we manage and treat these challenges? How do we manage these treatment challenges? We need to provide continuing care rather than episodic treatment. And we need to provide interdisciplinary collaboration. And even if we have to be the squeaky wheel and be the one calling and calling and calling, sometimes that is, I feel like for me as a therapist, that's what's required at this point. Not with everyone, but if I'm trying to do an interdisciplinary approach, that I'm going to have to be the squeaky wheel. We need adequate training and collaboration and involvement of colleagues from other disciplines to arrive at an accurate diagnosis. I used to work in juvenile detention, and unfortunately there are so many diagnoses that happen in so many different environments by the time they get to juvenile detention, they have, when they go through the process and they get their psychological, there's a history of 5 different diagnoses that don't make any sense. And I think, if we had a better ability to collaborate and we had a better ability in that setting to be able to really bridge the gap between one treatment placement to the other, that the client would be in a much better position to medically and psychologically and emotionally. So what is our definition of effective multidisciplinary collaboration? That is a tongue tire. The coordination efforts of conventional, complementary, and alternate practitioners working with the individual and the family. So we were talking earlier about, just multidisciplinary collaboration among professionals, but now we're talking about tying the family in. The goal is long-term biopsychosocial, cultural, and spiritual health. The basis is trusting the individual and family's intrinsic capacity to healing. The goal can be realized when all are connected with resources that enable them to access their inherent resilience, strength, and competence. There are 4 cardinal features of quality primary care: access, comprehensiveness, coordination, and continuity. The most significant predictor of treatment success is the provision of an empathetic, hopeful, continuous treatment relationship in which integrated treatment and care coordination are provided over time. So the need for continuing care in addiction and mental health. David and White, 2007, attributed inadequacies and ineffectiveness of the prevailing approach to treatment of addiction and mental health issues to the ever briefer models of acute care with little ongoing monitoring, support, and reintervention services. That's the other piece that I think is a big missing part. Even though if you can connect in multidisciplinary ways, follow up is really, really important. So not that first communication is not the only communication we have. As long as we are sharing that individual from a multidisciplinary approach, we schedule follow-up phone calls, we schedule follow-up emails, or whatever the case may be, in order to provide that wraparound service for individuals and families. We need to change the focus from cyclical episodes of symptom management with medication and cost containment to comprehensive collaborative continuing care. Okay. So and I would love for you guys to put this in the chat, please. Why do you all think families need to become members of a collaborative team? Thinking in terms of maybe the setting that you work, why do you feel like families need to be members of a collaborative team when considering co-occurring disorders?
Tell me when you want me to start putting it up.
Fabulous, thank you. Because families can support, excellent. Behaviors can sabotage the client, excellent. I love what you guys are putting up there. Agree with you all 100%.
Fabulous. Becomes a systems problem. Facilitate coordination. Can undo in 5 minutes what it takes 5 months. Yes. Oh, they've got it all.
Highlight, bold,
I'm just going to
bold.
put these up because I don't think they need them.
No, they don't need them.
They've done it all for us.
Codependencies, the family can know
They're
what's
the
going
real
on.
experts. Yeah, we bring our expertise, they bring theirs on the family.
Yep. Excellent.
Perfect. And then, of course, co-occurring illness is a family disease. Everyone has a role. These are fabulous, guys.
Absolutely.
And I think the slide is redundant. You've answered all of that.
I love this one, Judith. They are real experts on their lives and need to begin their journey of coming out of denial into acceptance. So
Yeah.
Considering the client and the family to be the experts. I love that.
Right. Yeah.
That's a good one.
Yeah. And of course, they go back to family. So if the family is not helped at the same time and everybody doesn't get healthy at the same time, we're back to the beginning of it all.
Yeah.
Yeah.
We're talking about intergenerational trauma, and we talk about the impact of how trauma extends beyond an individual, that it's extended into, the family. Yeah, you guys got a lot of these.
Yeah, they really did.
Yeah.
Yeah.
Excellent job. Okay, so I think, Judith, we may be ready for the case study, because I think they've covered this part.
Yeah, I think we've really done all of this.
Mm-hmm.
Right. Okay, so this is the person of concern, Brittany, drugs and alcohol from age 12, cutting, promiscuous, and kicked out of school. Can I have a quick, can you show hands or just do yes, no in the chat for whether or not you're able to read a genogram? But I do have, for those of you who can't, the next slide. Great, so we've got most of you can. Fabulous. So if we're looking at Brittany, and we start thinking about what is her background. Do we know anything about what was going on in her family when she was 15? So I can tell you the story rather than while you look at the genogram. She was born in 2003. She's 15. Middle child, older brother Sean, who was just accepted into Stanford, and younger brother Liam, 13. Parents, Abby, 14, John Jr., 55, married in 99, divorced in 2013. Sorry, hold on. John III, an executive, with an MBA and JD as an alcoholic, left Abby while she was in rehab to marry a co-worker in 2013. Abby had been depressed and addicted to benzos. He married his co-worker, Tina, who is also an alcoholic, and Tori. And Tori has a daughter, Tiffany, also 15 from a previous marriage to Tyler. And Tiffany gets straight A's and is one of the fastest runners on the track team. So you're beginning to look at those contrasts. But then if we look at what was going on with Brittany and Abby, Abby's in rehab during the divorce. She and Sean, the oldest son, are very close, and Brittany's closest to dad, who moves out, right? While her mom is in rehab. And we go back a generation and look at the trauma. And on the one side, and depression after losing a husband. And Abby was 1 year old when her dad died, and she then had a crib death at 6 weeks. Similarly, John J. lost his father at 14, and John J. number 2 was an alcoholic with a depressed mom, not just because of the loss of her husband, but they lost an 11-year-old who died of bone cancer after many years of illness with several amputations. So if you look at the timing, can you see how Brittany started having issues? And that this is not just the drugs and alcohol, but we're looking at co-occurring disorders in a 15-year-old. Okay. And pop your questions into the chat. We can get to them afterwards. So looking at how do we deal with co-occurring disorders in a situation that's as complex as this. So we're going to share a little bit about transitional family therapy, TFT, which is an example of why integrative family therapy is effective for multidisciplinary collaborative care. So TFT was one of the first integrative family therapy models. And rather than just looking at the here and now, or just looking at the intergenerational stories, or just looking at the context, we look at all three of those concurrently when we're doing our assessment. And looking at all of those with Brittany is clearly the only way that we're going to be able to design effective work. TFT philosophy, we believe that individuals and their families are intrinsically healthy with both strengths and vulnerabilities and the ability to heal. We're all in constant transition, and typically we cope well with transition unless there are 3 or more in a short space of time, and unless those transitions are really traumatic. We cope well if we're able to access and utilize our strengths and resilience and our support systems. So our key actions are empowering family, community, and natural support system, reinforcing connections to family and culture of origin, focusing not just on the individual and the family, but also on the community and context, healing and recovery, not pathology. The more we focus on pathology, the more we uncover the negatives. We work to resolve unresolved grief and trauma, and to mobilize and reconnect the extended natural support system.
There are particular strategies and techniques used with TFT. One is hypothesizing. So going into working with a family with hypothesis rather than thinking that you know what's happening. Let the family tell their story. Joining, mapping, and determining a level of intervention. Establishing positive goals. This is a strength-based perspective. We are identifying strengths, intergenerational themes, and scripts. Strategic prediction and intervention. And then family meetings, homework, continuum of comprehensive collaborative care is kind of how we work with TFT and Arise. Shifting the family perspective. This is a fun one, and I absolutely love it in the training that I do, and also the when I'm doing consultation with interns for Arise. Helping professionals understand why it's important to shift the family perspective, taking the focus off the individual person of concern. For example, rather than looking at Brittany in that situation, looking at the entire family system and seeing the inherent patterns that are happening and the strengths, and focusing on all members of the family, because families have spent a lot of time in those situations focusing on the one that they're most concerned about, and oftentimes don't do their own self-care. So if we focus on the family system, we get the family system strong, we shift the perspective, looking at the family as a whole, and getting, being able to heal for future generations and focusing on that, then the individual comes along that we're concerned about and feels a little bit more in power and control. All right. So as we mentioned, all individuals and families are in transition, and depending on environmental and cultural influences may be in sync or out of sync. And that's a really important piece with the philosophy of TFT, just knowing, how many transitions people are experiencing and how, depending on what's going on in their lives, that we can be out of sync. Looking at the transitional pathway, like I mentioned, at times of stress, when things are pretty out of control, people tend to disconnect from one another, and they oftentimes are not, they're more likely to isolate, and it disrupts their transitional pathway, going from past, present to future. And so what we do with TFT and Arise in the process is we have them move from the past despair into relief, resolution, and hope through the transitional pathway. So refocus.
Yeah. So what we can see if we go back to Brittany is an example of transitional conflict. When 3 or more transitions have occurred within a short period of time, 1 or more families can become symptomatic. And if you looked at how much happened to Brittany in that short space of time, she was the one who became symptomatic. And normal life cycle transitions can be disrupted during trauma or loss, especially ambiguous loss. And one of the individuals and or family's life cycle stages can become accelerated or delayed. So if we think about the 11-year-old and all the hopes and dreams that the entire extended family had for her, never mind her own hopes and dreams, this little one has gone straight from childhood to death, all the way through the normal life cycle transitions, while the family's expectations of her are to become an adult. They probably even had dreams about who she would be and what work she would do. So those kind of losses throw the whole family into a transitional conflict. And it doesn't have to be as dramatic as that. It can be an untimely being fired from a job, developing, failing a class, not being able to get to college, any major transition that takes us one person in a different direction from the expectations of the rest of the family throws them out of sync. And the way we get through transitions is by doing the tasks that each transition brings to us. And if you think about any one of the transitions going on for you or members of your family, when you get home or after this class, I'd love you to add up the number of transitions that you and or your family have gone through within the last 6 months, let's say. And then I'm going to ask you to do something additional, which is to add up the number of tasks that any one of those transitions required you to do. And then think about the number of transitions multiplied by the number of tasks. And that's why we get thrown out of sync when there are multiple transitions. It's because of all the additional tasks with each transition. And interestingly, where the general population gets thrown at 3 or more transitions, we as healthcare professionals tend to live at 5. So see how that compares with your experience when you look at this. And what happens during transitional conflict is that family roles become confused and need to be resolved, or they reverberate down the generations. And our coping mechanisms are challenged when resources don't balance with the stresses. So think about resources, internal resources, financial, economic, and family members, neighbors. When we don't have them to help pick up those extra tasks, the stress level is measurable by a balance of stresses and resources. And just to take a little look at the transitional checkerboard, which you'll have in your handout, which is going to be sent to all of you. The old days, if one of the spouses was missing, grandparents would hop in to help. Today, what happens where there are no longer grandparents around, one of the kids hops up, throws them into conflict with the others, and they may even hop up to take care of the remaining patient, the remaining spouse. So if you think about siblings having to be stepped up and parentified and maybe even becoming grandparents, and then if the missing parent returns, they're now sitting up here, and it creates conflict in the marriage, conflict in the parenting, and we've still got the sibling conflict. So it's just a concrete example of how, when there's transitional conflict, the relationships start getting skewed, and how we can come in to help them. And this is what we needed to do with Brittany. And we needed to meet with the whole family to have them understand why Brittany had become symptomatic and to help her heal, along with the whole family and all of their unresolved grief. So we'd like to open up to some of the questions, Christy, if you can come back in and share any that are particularly relevant.
Yes. Wow. Thank you so much for that. Y'all go ahead and throw your questions in the chat box. I know Shema has one right off the top. First of all, she thanks you for the presentation, and she feels that this is not the way most care is done here in the U.S. There is so much emphasis on HIPAA and confidentiality. How can we respect that while gaining the insights and advantages that this family involvement can provide? And what about during acute or inpatient care?
So one of the things that we do with permission right at the beginning of an admission is we first have have releases of information signed by the client and the family, so that we can collaborate with the family, and we ask our treatment centers to insist that those releases of information are signed prior to admission. And we often work with treatment teams and intake teams to help them achieve that, so that they know how best to make sure that on treatment entry that the releases of information are in place. And we also ask that another form be signed, which is that if the person asks for premature release from treatment, or to sign out against medical or clinical advice, or to withdraw release of information, particularly from family or from us, that form gives they sign a form saying, if I request one of these, I give the treatment program permission to delay until my ARISE person and a family member have been contacted. And they sign that at admission. So that's one of our ways, Shema, around this. We have a number of other techniques that we use, but those are concrete and easily transferable.
Yeah, she followed up with, isn't that part of the challenge that these family relationships are acrimonious and may not want to cooperate with therapy?
So working from the positive perspective and mobilizing family from not focused on the patient, but focused on all of the person of concern, but focused on all of their needs, tends to obviate that to a large extent. And we do a lot of training and consultation around how to bring in acrimonious family members. I mean, we have a number of ways of doing it where we, in our first meeting, set very clear ground rules that this isn't all about the person of concern, and that we work in a sacred space. People have to use I statements, not you statements. They have to be polite. And if they find in a meeting that they're having trouble being polite, everyone at the beginning of the meeting identifies someone they can leave with a promise that they'll come back within 5 minutes. So if people get heated, we suggest, who's your accompanying person? Take a little time, come back when you're ready. So there are a number of techniques by which we soothe things down and remind them of the ground rules at every meeting.
Wow, perfect. So Carolyn would like to know, what drives your organization to emphasize abstinence over harm reduction?
Now, harmony is total abstinence.
Yes, we are.
We work with ARISE, we work primarily with, we work with outpatients, we work with IOPs, we work as collaborative team members with residential programs. So if we're working with, with an outpatient program where harm reduction is preferred, we would work with harm reduction. If we're working with an abstinence-based organization, we would honor that. When we're working on our own prior to admission or after discharge, there are times where we would go with harm reduction, depending on what the underlying co-occurring diseases are. If somebody is on psychiatric medication for a long-term chronic relapsing illness, we wouldn't dream of having them abstinent. For me, being in recovery for 60 years, I believe in abstinence with SUD. I believe in abstinence with gambling. But there are certain eating disorders. I don't believe in abstinence of eating for someone dealing with compulsive overeating or bulimia. So I'm sorry, it's a little clumsy, messy answer, but there you have it.
Thank you. I think we have one more question from Lisa. She would, how would you involve family, especially parents who are themselves struggling with addiction and mental illness?
Michelle?
Sure. That is something that we very commonly see. It's rare when you're looking at the genogram, any sort of genogram, you'll see patterns of mental illness and patterns of substance use, and it's not uncommon that we do that. Every family member of the family network, or every member of the family network, is responsible for their own self-care and goals. And so if there are other people struggling with addiction, oftentimes we see not only the person of concern, but multiple people go to treatment. Multiple people get counseling and family counseling, individual counseling, all the above. So one of the things that I find in the work that I do is typically when I'm working, with a family network, that everyone's doing some sort of self-care, and for those that are struggling with their own addiction and mental illness are oftentimes getting the help as well.
Yeah, we we work in minimally 6-month contracts. So we do a wrap around with the family while the person's in treatment. We'll work with them afterwards. But our goal is the individual and every family member gets healthy and
Yes.
does their own work.
Dr. Landau, Dr. Holcomb, thank you so much for today's presentation. It was fabulous. I learned a lot, made me think a lot about, I'm adopted, so I think a lot about tendencies and where my medical history could be, might be, had been important somewhere in there. So I so appreciate you taking the time to join us today. Y'all, I will be sending out your emails with contact information, handouts, links, all the things. So if you want to revisit this, you can. Please remember that December, we will not have a webinar. We will be reconvening in January. So stay tuned for that information. I wish everybody the happiest of holidays. Stay safe. And again, Dr. Landau, Dr. Holcomb, thank you.
Well,
Thank you,
Christy, for your hospitality, and enjoyed being with you all.
Thank you so much, everybody. We'll see you next year.
Happy
Bye.
holidays. Bye.